He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
All right, welcome back, folks. This is the Stay Off My Operating Table podcast, and our guest today is Dr. Bret Scher. I am looking forward to this conversation for reasons that are more personal to me. Phil, why don't you set it up for us?
Yeah, really excited to finally have Bret on the podcast. Many in my audience probably familiar with him. Bret is, I think, one of the original cardiologists that sort of came to the low carb space, at least prominently. And I've been, following him for a long time and interacting with him as I got more involved in the low carb community. And now he's doing some new and exciting things within the low carb space that we want to talk about as well. But before we get into that, Bret, why don't you give a little bit more of your background to our audience?
Yeah, thanks, Phil. I appreciate the opportunity to be here. And I still remember meeting you at Low Carb Boca at one of those conferences and saying like, oh, cool, cardiac surgeon, that's what I need. I need a compatriot in this journey from the surgery standpoint. So I'm very excited that you are in this field spreading this message as well. But so just a quick background on me. I'm a cardiologist. And when I did my fellowship training, it was in a combined preventive and general cardiology fellowship. I always knew I wanted to focus on the preventive side of things. And, when you're a fellow and you're in a preventive cardiology fellowship, you kind of think you're going to change the world. And it's like, yeah, I've got all the tools to just stamp out heart disease and help everybody I see. Then the real world sets in and you realize that's not happening. And, you can only go so long saying, oh, the patient did not comply. I hate that word, did not comply with nutritional recommendations or lifestyle recommendations, or lifestyle recommendations did not have the impact we were hoping for. So you whip out the prescription pad, and it was sort of like a revolving door. And eventually I had to stop and say, what is going on here? Why did my probably naivete and, enthusiasm in the beginning turn out like this? And initially I thought it was just, I needed more time with the patient. So I started Boundless Health, which is like this kind of boutique wellness center. And I was working with a friend of mine who's a health coach. And I thought I just needed more time. But luckily for me, the health coach that I was working with, he was very knowledgeable about nutritional ketosis. And for a couple of patients, he said, hey, maybe we should try a keto diet on this guy and see what happens. And of course, my reaction as a well-trained cardiologist was, what are you, crazy? Like, we can't do that. We're going to kill the guy. It goes against everything I was trained to do. But luckily he said, well, have you looked into it? Have you studied it? Have you read about it? And I had to be honest and say, no, actually I haven't. I'm just going off of, what I was taught basically, which is nothing about a ketogenic diet, just the concept of fat is bad. But then once I dug into it, it was eye-opening that there were studies about it and there was good outcome studies. And then of course there were books and articles. And the more I read, the more I thought, well, wait a second, why have I not heard about this? I've got to dig into this. So then I started eating that way, started using it in a number of my patients, and to see patients who have, quote unquote, tried everything and been unable to lose weight, unable to improve their type 2 diabetes, unable to improve their metabolic health. And to see it just all of a sudden work, all of a sudden improve with this nutritional approach was eye-opening. And that's what got me on this road, and to say, look, I want to be an advocate. I want to talk about this because, if for no other reason, because it's not being taught. It's not, doctors coming out aren't learning about this. And it's because of this just backwards dogma that's been around forever, that fat is bad, saturated fat is bad. You have to eat, you need your carbohydrates. The brain, the body needs carbohydrates, right? That's what we're taught. And it's so backwards and incorrect. So that's what led me to this space. And it's amazing how many people we can help.
Well, I'd like a personal testimony. You tried the diet. What was your experience as you began?
Yeah. So I had two young kids at the time, and I'm fortunate. I was never overweight. I was never, metabolically unhealthy. But
I
being
see
an
you
athlete,
suffer from hair loss, though.
That is something that keto did not solve. I can testify
I can
to
also
that.
testify to that.
We got three of for that one. Yeah.
But I did put on the post kid, weight, and it was, maybe 10 pounds heavier than I would have wanted to have been from my, athletic days. And boy, did that weight just come off when I went on a keto diet, and my body composition improved. I did DEXA scans, I gained muscle, I lost fat, and I felt better. I was sleeping better. I had more energy. And I thought, if this happens to me, someone who thought I thought I had no quote unquote problems, right? I thought I was doing just fine. What is this going to do for someone who has type 2 diabetes? What is it going to do for someone who has 30, 40, 50 pounds to lose? What is this going to do for someone who has mental fog and fatigue? And that's what really started it. So I noticed the changes in myself and realized it could be magnified, tenfold in people who really needed it.
Well, you are, in my research, I just went straight to your website, metabolicmind.org. How did a cardiologist end up working? Tell us about Metabolic Mind, and then how'd you end up there?
Yeah, it's a good question. So, in my cardiology practice, I started using nutritional ketosis and focusing on metabolic health as it relates to cardiovascular health. And that's the other sort of connection here, the realization of how important metabolic health is. And it seems simple to say, but in cardiology, there's, you don't focus on that. You focus on LDL, you focus on blood vessels, you don't focus on glucose and insulin and inflammation and the concept of metabolic health. Well, now, hopefully that's becoming more common. That's certainly what I was focusing on. Then I transitioned to be the medical director at Diet Doctor, which was really focusing on metabolic health and nutritional ketosis. But then I learned about Metabolic Mind, and I learned about the Bazzucchi family and what they went through with their son, Jan and Dave Bazzucchi, Dave, who's the CEO of Roblox, what they went through with their son, Matt, who had bipolar disorder. And really just one of these stories that breaks your heart, that, here's a family with lots of resources and a very intelligent family, and their son is really struggling with this mental illness and in and out of hospitalizations, homeless for a while, and could have ended tragically, and often does end tragically for people. Fortunately for them, it didn't. But nutritional ketosis, starting a ketogenic diet, is really what turned his treatment around and what gave him his life back. And realizing that so many people
stop.
Yeah.
Say that again. That's
It's remarkable. I mean, the medications can help someone who is acutely psychotic or manic or suicidal, but they don't necessarily give you your whole life back. And this was Matt's experience. He was being treated, but he was numb. He was not experiencing life and living the way that it was quote unquote normal, right? But once he started on a keto diet, that's when things changed. And you can hear from other people too, from Dr. Ian Campbell, who's a researcher. He said, that's when the lights turned on. And he says, oh, this is how normal people feel. I can appreciate the birds singing. I can appreciate the sun shining, which is something that for a number of people, obviously not everybody, but for a number of people, the medications to treat psychiatric illness prevent that from happening. But through nutritional ketosis, they were able to achieve that. And now living life, independently with living with friends in an apartment, having a high functioning, high executive job with no stigma of mental illness like that. It's kind of not supposed to happen, right? Mental illness is not supposed to go into remission like that. So hearing these stories made me think like, wow, I mean, this is an opportunity to change the way medicine is practiced, to change the way an entire field is practiced and help people who are really struggling. And that's what Jan keeps saying, that she wants to provide the information that she was looking for, because this took her years to get to this point. She doesn't want families to suffer and to struggle for as long as she and her family had to. If we can find a way to speed that process up and educate people. And I thought, I'm in, because it's about the metabolic health. It's about ketosis, which I know about, and then collaborating with the people within the field of metabolic psychiatry to combine those fields to really help people. So that sold me right away.
So, Bret, we've been talking for just about 5 or 10 minutes, and we've already basically mentioned two major areas of medicine, cardiovascular health and mental health, that, ketogenic diets, therapeutic ketosis can have amazing effects on. And yet, you and I never heard about this in medical school. We
Right.
graduated medical school about the same time, and we never heard about it in medical school. And, we both had to sort of come across it, accidentally, or, looking for our own answers. What are your thoughts about that? And what do we do to change that for the healthcare system?
Yeah, I mean, my first thought is just absolute frustration. Like, how can this be? But once you get past the frustration, then you realize, okay, well, we have to be the voices. And it's podcasts like this, right? It's conferences, it's talking to doctors, and that's one part of it. But the other part of it is, how many physicians have you and I come across, Phil, who say, yeah, I'm here because a patient of mine brought this to me and showed me what they could do. And then I had to learn about it, right? So doctors can learn from their patients. So really, we have to approach it from two perspectives. We have to educate the person who can become the patient to then educate their doctor through their personal journey and their success. And we have to reach out and let the doctors know. And I mean, gosh, doctors want to help people, right? That's why we went into medicine. But unfortunately, a lot of doctors are burnt out and beat down, and it's because of the system. It's not because they don't want to help people, but because the system they're in is really not optimized. But if we can show them a way to sort of reinvigorate their connection with their patients and to help their patients in a way that they haven't been able to before, I think that they'd be all in on it. So it's part of that, trying to open their eyes to it. Now, unfortunately, there's still a lot of stigma and sort of negative perceptions around keto diet, and recent news to the point, which we can talk about, but the fear of saturated fat, the fear of LDL. So we have to address all those as well. And I think that's sometimes where we can be, meaning, sort of the low carb movement, can be our own worst enemy, right? If we say, look, everything you're doing is wrong, medicine, everything you have it completely backwards. Well, what are they going to do? What's a doctor going to do? They're going to shut down and not want, and just like any communication strategy, that's not how you communicate with people. So we really have to sort of bring them into the fold in a way and show, like, look, we can do this just a little bit differently in a certain subset of people. Here are the therapeutic indications for nutritional ketosis. Here are things to consider, rather than being confrontational, showing a yes and approach. That's how I like to approach it. And I think that's how we can hopefully make some headway. And it's going to take time because the tradition is so steeped in the opposite approach. But you and I have seen it. Once you see this change in your patients, it's impossible to unsee or forget about.
Yeah, I think that's very true. And, extending that, so how do you, approach some of your colleagues these days when the big questions come up? And we'll go back to cardiology field for this, but, the saturated fat issue and the cholesterol issue. And, we have seen the evidence that, that goes against that narrative, but most physicians don't see that evidence. It's just never even presented to them. And how have you handled those discussions with your colleagues?
Yeah, it's a great point, because we are trained saturated fat is bad, end of story. Eating fat is bad, end of story. Any elevation in LDL is severely dangerous, end of story. And because people like simple answers, right? It took 3 seconds to say those statements. Well, now if I'm going to say what is really the case, it's going to take me, 10 minutes to describe in detail what the real situation is. And it's a lot harder story. But the story is, well, within the context of a standard American diet, for those people eating high saturated fat, high carbs, high calories, processed food, sure, that combination is very potentially dangerous and could lead to poor cardiovascular outcomes. If your saturated fat is coming from a pie crust and cookies, and that's where your saturated fat is coming from, okay, sure, that's likely going to be this combination of fat and carbs and poor metabolic health and poor cardiovascular health. But that is a completely different story than if we're talking about eating a diet that is low carb and the fat is coming from natural animal sources, not ultra processed. It's not hypercaloric. It's within a setting that's improving your metabolic health. That is a completely different scenario, but that takes longer to say. That takes longer to think about. That's a nuance that is not easy to understand when you haven't seen it, and you haven't considered it. But I think that's the first step, is to say, look, what are the studies that we're basing our recommendations on? How strong is the evidence? Well, the vast majority are these large population observational studies with very low hazard ratio and healthy user bias and confounding variables.
To define those two terms, I'm not a healthcare professional.
Right. So a study where all you do is observe how people are living at time A and observe how they're living at time B, see who has heart attacks, who doesn't, and then say, okay, let's just collect all this data. What were they eating at time A? Frequently never assessed again up till time B, with just a form you fill out, and then say, okay, who lived, who died? Okay, well, the people who ate more fat had more heart attacks. But the other thing is the people who ate more fat exercised less, smoked more, slept less. They were also eating more sugar and more calories. So this is what's called healthy user bias. That in the 90s and early 2000s, if you were obeying the health message, what were you doing? You were eating less fat, right? And if you were disregarding the health messages, what were you doing? You were eating more fat. So that's healthy user bias. And then there are low hazard ratios. So the risk of red meat and heart disease has a hazard ratio of 1.2. So that's how much more likely you are to get heart disease. Now, for perspective, that same type of study, when you look at smoking and cancer, it's between 15 and 30, not 1.30, but 30. And now we're talking about 1.2. So it shows it's a minuscule statistical effect. So the point being that all of those things, that's where our evidence is coming from, where we're making recommendations that you cannot eat saturated fat, you cannot eat red meat, when it is the weakest quality evidence there is. And it's within the context of a completely different diet, a completely different way of living than we're talking about now. But like I said, that takes a lot longer to say than fat is bad, saturated fat is bad, red meat is bad. It's a completely different message. But I would hope as physicians, we would want to know that. We would want to know those nuances because, there are guidelines, but guidelines are based on the general population. I'm not the general population. You're not the general population. Any person listening to this is not the general population. We're individuals and we deserve to be treated like individuals. And that's where this concept of, okay, well, what is your whole dietary makeup like? What is your whole lifestyle makeup like? What is your metabolic health like? What is your cardiovascular health like? What are your labs like? We have to incorporate all of that. And that is more difficult to do than just say LDL is bad.
So if I could put it in what I think might be plain English terms, the way these guidelines should be interpreted by us lay people is, all else being equal, if you eat less meat, eat less red meat, you have a slightly lower chance of having a heart attack. But we all know that all else is never equal.
Right. That's the key, right? If you are someone who is well represented by this study, and the people who ate more red meat, like I said, smoked more and drank more and exercised less and ate more calories. So yeah, if you fall into that bucket, then your risk is slightly higher. But if you're not in that bucket, then that evidence just doesn't apply to you.
It doesn't apply.
Yeah.
Very good.
Yeah, and I think that's a nuance that honestly, healthcare professionals have trouble with, because the reality is that doctors are very busy and usually don't have time to go read the studies. And we just got the message during school and in our ongoing education, that the message is always saturated fat is bad for you. And, we don't have time to look into the nuance of it often. And so it's like you said, it's easier just to say saturated fat is bad and move on. So I'm glad, you're out there and so many of us are out there now. I'm always encouraged by going to the conferences, and we were both at a conference a few weeks ago. at the time we're recording this. And, you know, it's amazing to me to see the increase in the number of physicians and all the different specialties being represented.
Yeah.
You know, that we have more cardiovascular specialists, and we have a lot more mental health specialists, you know, at these conferences these days. And we have, you know, the GI doctors and the kidney doctors, and you know, it's almost hard to think of a specialty that wasn't represented and isn't represented at the meetings these days. So I think that gives me a lot of hope. And the other thing I'm noticing that I'd like to hear your perspective on is there seems to be younger doctors, earlier career doctors that are finally getting this message. And we have some prominent, you know, medical students even these days. We had Nick Norwitz on previously, and there are a few others that are leading the movement for, you know, I guess I'm starting to sound old because I'm going to say the next generation of doctors here. So that gives me encouragement as well.
Yeah. And I think the new generation is asking questions, you know, is asking, well, why is this? And I think that's so important. And I actually have a funny and sort of embarrassing story at the same time. When I was chief resident, so many years ago, I remember one of the interns came up to me and we were talking about aortic valve replacement. And the recommendation is you don't surgically replace an aortic valve unless you are symptomatic, unless someone is symptomatic. And he said, well, why not? Like, why can't you replace it earlier when someone's healthier? And I didn't want to hear it. I said, look, the guidelines are what the guidelines are. You don't replace it until symptomatic. I wasn't even able to ask the question at that moment. And that's what the embarrassing part, right? Because we should always be questioning. But I'm not alone. I think there's so many doctors who are just like this. But this new generation, I think, is starting to ask those questions and starting to ask why. And when they hear someone like you talk, when they hear me talk, when they hear others talk at these conferences, it helps them kind of further ask that question of why. So I think that is really encouraging about this new wave of physicians. And you're absolutely right about the number of specialties. Like, absolutely, endocrinology should know everything about nutritional ketosis because of what it can do for putting type 2 diabetes into remission. A word I had never heard, I don't know, more than 5 years ago, maybe, or 10 years ago for sure, never used hardly at all. And now very common to put type 2 diabetes into remission. So every endocrinologist should know about this. And every cardiologist should know about it, because triglycerides, HDL, small dense LDL particles, VLDL particles, the advanced lipid testing that unfortunately isn't done enough. This is how you improve it. And now every mental health specialist, which includes the majority of primary care doctors, needs to know about this, because nutritional ketosis is an effective treatment for so many either both neurologic and mental health disorders. And now all the obesity medicine specialists, unfortunately, there's so much emphasis on drugs and surgery that there's less of an emphasis on lifestyle, but every obesity medicine specialist needs to know about this as an effective treatment for obesity. So yeah, all the specialists coming together. And I think that the future is bright. I mean, we're only going one direction, which is more people becoming aware of this. The question is, how do we speed it up to help those people who are looking for help now?
Yeah. And you know, the example you gave, that story from your residency, is real interesting, because here we are 20 years later, and today we routinely replace aortic valves in people who are not symptomatic. And we know that there's an advantage to doing so. So, you know, medicine does change, it does evolve, and we need to keep pushing that forward. So, you know, talk a little bit more about the relationship between mental health and dietary ketosis. You know, what should the doctors that are out there in the audience know about this, and what should the people that are suffering from this know about it?
Yeah. Well, I think what's really interesting is you can look at this from two different perspectives. You can say nutritional ketosis for mental illness is a brand new field without all that much research. There are a number of case reports. There's a non-randomized study out of France, and there's clinical experience. Or you could say we have over 100 years of clinical experience using nutritional ketosis for brain function in seizures and epilepsy, and over dozens of randomized controlled trials and Cochrane reviews of nutritional ketosis for reducing seizures. And that translates to mental health, because the brain is the brain, right? We're talking about brain function. The same medications used to treat seizures are the same medications used to treat bipolar disorder, schizophrenia, depression, mood stabilizers. The mechanisms involved in seizures, many of them are very similar mechanisms for mental illness. So treatments for one tend to benefit treatments for the other. So depending on how you look at it, you can either say there's not a whole lot of evidence yet, or you can say there's dozens of randomized controlled trials and Cochrane reviews. But regardless,
what kind of reviews? You use that word twice now.
Cochrane reviews. So those Cochrane reviews are published reviews where they look at a compilation of the different studies, and they'll pull all the different studies and randomized controlled trials and come up with sort of like a consensus review of what all those studies show.
Is that like a meta-analysis?
Yeah, it's like a meta-analysis is
Okay.
is a good way to think about it. I should have just said meta-analysis. Yeah.
Okay. Sorry, didn't mean to derail you.
Thank you for keeping me speaking English so people can understand here.
Well, you know, we've got two different audiences for this show. We've got the healthcare practitioners, and I love it that you guys are able to speak to them in a way that they can both appreciate and respect.
Mm-hmm.
But us lay people here, sometimes you guys are over our heads. So I try to keep that balance.
Yeah,
right.
I appreciate that.
I've got a question that keeps recurring for me, and maybe the answer has just not stuck in my mind, but is there a difference between nutritional ketosis, air quotes, and a ketogenic diet? I hear the phrases used what appears to me to be interchangeably, and I don't know whether that's true or not.
Yeah, I mean, for the most part, I think they are interchangeable. I like the term therapeutic nutritional ketosis because that's the goal. The goal is to have your body change its metabolism, to be in ketosis, to have your brain using ketones for fuel, and to get there through a nutritional intervention. Now, that is basically a keto diet. You know, a keto diet can mean a lot of different things to a lot of different people. So saying therapeutic nutritional ketosis cuts through the stigma or the biases of a keto diet and shows it for what it is. It's a medical intervention. So my talk at Low Carb Denver was basically about when is a diet not a diet. It was about a medical intervention called therapeutic ketosis, because that's what we're doing. We're using it like you would use any pill, like you would use any medical intervention. We're changing the body's physiology in a way that is going to be beneficial for brain function and reduce mental health symptoms, or in a way that's going to change the body's physiology and put type 2 diabetes into remission. It's a medical intervention using ketosis. Now we get there through following a ketogenic diet, which is going to be different for different people. So we just released a video at Metabolic Mind where I'm interviewing Beth Zupek-Kanya, who's a dietitian with decades of experience in ketosis for epilepsy. And we talk about the 4-to-1 keto diet, the 2-to-1 keto diet, the modified Atkins diet, basically different versions of the keto diet. And they all work. They all work for reducing seizure frequency, and they're likely all going to help mental health in different ways. So it's this concept of nutritional ketosis, kind of however you get there is the end goal, is how I see it.
And
Bill, do you mind if I drill down into one more thing you said?
Yeah, I was just going to throw in to, build on it, because I'm not sure we've mentioned it on the show before. The ketogenic diet was initially developed as a therapeutic diet for epilepsy and seizure disorder. So I just wanted to make sure people understood that.
Right. When they fasted kids, their seizures would improve. But you can't fast long-term because you're not going to survive. So they said, okay, let's develop a diet that sort of mimics fasting. And it was a very high fat, low protein and low carb keto diet. And that's the initial 4-to-1 diet that was used for seizures. That's how it came about. Now it's being used for weight loss and people just feeling better and brain fog or whatever. But we've learned that it doesn't have to be that strict 4-to-1 keto diet. Now, what's called a modified Atkins diet is kind of like the more popular everyday keto diet, that like 25% protein, 70% fat kind of diet. Yeah. So,
And that's
but
closer to
you're
3 to
right.
1.
No, that would be more like a 1-to-1 most likely, because it's grams of it's not percentage. So the
Oh,
3-to-1, 4-to-1 is not percentage. It's grams. So it'd be grams of fat compared to grams of protein and carbs. And remember, you get a lot more calories per gram of fat, so it's not the same as the
right.
percentages.
A
Yeah. So
gram of fat is 2.5 times the calories as a gram of protein or a gram of carbs.
Yeah. Yeah.
Okay. All right. Okay. That is, there was just a lot of fogginess around all that for me. And I appreciate you clearing that up. Would you mind now? Let's get deeper into Metabolic Mind, what the organization Metabolic Mind is about, what you're doing, and then specifically, what are you specifically doing with Metabolic Mind?
Yeah, so I'm the director of Metabolic Mind, which is a nonprofit initiative of Bazooki Group, thanks to the philanthropic efforts of Janet and Dave Bazooki. And we want to provide information and resources at the intersection of metabolic health and mental health, so that people can learn that this is an option, and they can learn the science about it. They can learn the practical applications of it and the potential concerns about it, and basically how to use nutritional ketosis and metabolic treatments to improve mental health and improve symptoms of mental illness. But most importantly, how to discuss this with your provider. Because one thing we're very clear about, if you're using ketosis as a medical intervention, you don't want to do it alone, because there are some concerns. It should be done with medical supervision, with experienced clinicians. So we want to provide that information to the individual so they can bring that to their clinician. We want to be the resource that both patients and clinicians and family members can come to learn how to do this safely and effectively, because we want to change the way psychiatry is practiced, and we want a focus to be on metabolic health. There is a clear association between metabolic dysfunction and psychiatric illness, and it works both. The connection works both ways. So that's what we're doing at Metabolic Mind.
By both ways, you mean people who have been diagnosed with some sort of psychiatric condition almost definitely are presenting, actually have metabolic condition as well that is possibly just not diagnosed.
Right. So those who have a diagnosed psychiatric illness are much more likely to have metabolic dysfunction. And those who start with metabolic dysfunction are much more likely to go on to develop a psychiatric diagnosis and develop a mental illness. So sorry, that's what I meant by works both ways. Yeah.
Very good.
So we need people to be aware that this connection exists. We need clinicians to be aware that, I should be testing my patients for metabolic dysfunction, or I should be screening them for mental illness. And I can use a treatment focused on metabolic function as a treatment for mental illness as well. Not the one and only treatment, but part of the treatment plan. So that's what we're sharing resources and information about that. And we're also funding the research. So we have 5 pilot trials that we're funding right now, 2 that actually have completed are going to be presented in June. So it's very exciting to see those results, and 3 ongoing pilot trials, because, there's time in medicine where the clinical experience and the enthusiasm is ahead of the research. And that just happens because the research takes time to catch up. Now, when we're talking about a drug, you need the research, right? The drug's not going to be approved until you've got the research. But we're talking about nutrition, so anybody can do it. So we have to fight for the research to happen because Big Pharma is not paying for this research. So we're trying to fund the research so the research can catch up. So we have to ask the question, what do we do for the person looking for help now, who's desperate for an answer now? And how do we change the minds of clinicians and the field of psychiatry as a whole over time? So that's why we're approaching it from an information standpoint and from a research standpoint.
And, obviously you can't, give us the results of those studies, but, outside of the studies and even prior to the studies, you had a lot of clinical experience, and many of our other colleagues have had their clinical experience. I just want to talk about sort of the, let's say, the magnitude of response that we tend to see with these diets. And we touched on it earlier, when you talked about the Bouzouki's son getting his life back. But, you know, the magnitude of response to these dietary changes just seems to be far and above anything we typically see with drug therapy. It's rare that someone with mental health problems gets, you know, dramatic responses from drug therapy. They usually get, you know, mild to moderate responses, I would say.
Yeah. And with side effects. And that's the problem. You know, psychiatric medications come with a lot of side effects. And that's just the nature of them, you know, medications that affect your brain. Now, look, there are people who have bipolar disorder and have had manic episodes and take lithium and do phenomenally, right? Those people that exist. So I don't want to discount that. But there is a large percentage of patients who have side effects, who need multiple medications, who have treatment-resistant disease. And they're desperate for any kind of treatment that's going to help them get better. And that's where you can see this magnitude of effect. And the analogy I like is with type 2 diabetes. You know, is the goal for many guidelines is to keep someone A1C around 7. So keep cranking up the insulin, do what you have to do to get to the A1C to 7, which is not a normal A1C. But with people following a ketogenic diet, they have A1Cs of 5.2 off medications. Like, that's the magnitude of effect. It's so much more dramatic than any medication. And I think we're seeing the same thing within the field of psychiatry and metabolic psychiatry.
You made the comment that nutritional therapeutic nutritional ketosis diet also has some positive negative side effects, and that's why people should work with someone who knows what they're doing. What are some of the biggest potential problems?
Yeah, great question. I'm glad you asked that. So first and foremost is sleep. So I think a number of people, when they're first transitioning into ketosis, will experience some sleep disruption, which for, you know, someone without mental illness is not that big of a deal. You're a little tired the next day. But for someone who's prone to hypomania or mania, or prone to psychosis, or prone to severe depression, significant sleep disruption can trigger that. So that's one thing people definitely need to be aware of. So if you talk to Dr. Chris Palmer, who's a very prominent spokesman for this, he'll say, look, you have to measure your sleep. You have to track your sleep. And he will use sleeping medications as needed, or even increase the antipsychotic medications temporarily for this transition phase to help people get through. You know, the keto flu is something people hear a lot about. Again, for the average person, keto flu might make you feel a little crummy, but for someone prone to severe depression or to mania, then keto flu might mean something completely different. So you have to be on guard for that. Your energy levels change. And the other thing is, it actually, being in ketosis can change medications levels. So Depakote, valproic acid, medication levels can change within your body. So you have to be aware of that, because a psychiatrist may check your levels and say, oh my goodness, your levels are down. We need to increase your dose. Well, maybe or maybe not. If you're actually feeling better with a lower level, that could be a good sign, but it's something that both the patient and the doctor need to be aware of. So there is a sort of constellation of effects that you definitely need to be aware of as you're transitioning into ketosis.
What about, do you have similar kinds of concerns for folks who are adopting nutritional ketosis, who are not dealing with mental health issues, who are doing it for non-mental health reasons?
Yeah. Well, if you're doing it for type 2 diabetes and you're on insulin or sulfonylureas, your blood sugar is going to plummet. I mean, you're victim of the success of a ketogenic diet. It works so well that your blood sugar is going to go dangerously low. So I also recommend anybody on medications for their blood sugar to work with a clinician, because you'll need to taper down your medications safely. So there's that. Similar with blood pressure, although not quite as dramatic as blood sugar. But I think for the average person on no medications, with no mental illness, wanting to feel better or wanting to lose weight, then I think starting a ketogenic diet is perfectly reasonable for most people. Now, they still need to be aware about the keto flu. They still need to be aware about the need for hydration and electrolytes. But you can get most of that from, dietdoctor.com, from different websites, from from Phil's information that he's putting out, right? Like you can get that information out there. But if you are using it to treat a medical condition, then you absolutely should be working with an experienced clinician.
Very good. That's good to hear.
Great. So we've talked about what Metabolic Minds is doing for the patients. We've talked about some of the research that it's doing. Let's also talk a little bit about, the resources that they're trying to make available to the clinicians that want to, use this for their patients, because ultimately to scale this, we need more clinicians that are familiar with therapeutic nutritional ketosis and are comfortable utilizing it with their patients.
Yeah. Yeah. So one of the nice things about Metabolic Mind is, like we're not selling anything. We're not a company out there to make money. We want this field to grow. We want the information to get out there. So one of the things we do is promote what others are doing. So Dr. Georgia Ede has a clinician training course, which I highly recommend any clinician interested in learning more about this should take. You get CME credits for it. And it's a very good course to get to train the clinician how to use nutritional ketosis for this. Denise Potter and Beth Zupek-Kanya have a ketogenic mastery course and a fundamentals of nutritional ketosis course, where you can learn from the nutritional side how to start a ketogenic diet, how to help people with nutritional ketosis. So those types of courses we want to promote. We want as many people to know about as possible. Then we have our whole YouTube videos, which are really mostly patient focused, but I try to do them in a way where clinicians will also be able to learn from them, and clinicians will be able to say, this is something I need to know more about, and this is how I can help my patients with it. So those are the resources we're working on now, and we look to and hope to build even more, and both for the clinician and the general population. And that's part of the problem. It is definitely harder to reach clinicians, especially busy clinicians who don't know about this and aren't looking for this. Those are the ones we need to reach, the ones who aren't even looking for it and don't know it exists. But once they learn and once they see it in their patients, they're going to wish they knew it all along.
So what would you, if you could, kind of get in the time machine and go back 20 years to when, we were finishing medical school and going through our training, what would you tell yourself?
Yeah, great question. Great question. I would tell myself, first I would tell myself, ask what the quality of evidence is, because I don't remember ever being taught or thinking about what is the quality of evidence. It was the evidence shows, the paper says, and not what is the quality of this evidence and how strong is the evidence. So that's the first thing, to ask the questions about the strength of the evidence. And two is to realize that nutritional science is poor quality science, and the strength of the recommendation does not match the strength of the evidence. And therefore we need to ask questions about, is this true? What does this mean? What are the alternatives? And what is the evidence against the alternatives? We need it when there's that much of a mismatch between the strength of the recommendation and the strength of the evidence. We need to ask more questions.
Dr. Scher, I read something there on your website where you talked about that mismatch between the strength of the recommendation and the strength of the evidence. Mm-hmm. I don't remember what it was. Give us an example.
Well, yeah, I mean, the best thing is red meat is awful for your health. It's going to cause cancer and heart disease, and nobody should eat it. And that evidence is so poor. And in fact, there was a publication in the Annals of Internal Medicine where they used this grade criteria, GRADE, an acronym, to say, what is the strength of the evidence? And the conclusion was there is no good quality evidence to support that recommendation, that the evidence supporting it is very poor quality. And this was in a peer-reviewed medical journal, but yet it doesn't necessarily change the message. So that is a perfect example of the mismatch. And look at the dietary guidelines, right? The dietary guidelines are another perfect example. They are set in place as if this is the healthy way to eat, and we should not question it, because this is what all the schools have to do. This is what all the nursing homes have to do. This is what the dietary guidelines for Americans are. And it is based on extremely poor quality evidence. And so that mismatch it's rampant, unfortunately.
I remember, gosh, I'm trying to remember the specific example. It has to do with what today goes by the phrase energy medicine. But back in the from the 19th to the 20th century, Nikola Tesla was doing an awful lot of work with electricity. And amongst the things that he was working on, that he personally had experienced himself working with electricity, were some types of healing. And he was drawing people to his lab in Manhattan, I think, to be treated. And it wasn't remotely what we would call good research that could be extrapolated across the population, but there was promising results. And treatment with electricity was starting to get some traction. And as I'm researching some stuff related to this, I find out that around this same time, the Carnegie Foundation, which was one of the major funders of medical schools, notified the medical schools that they would stop getting funding if they taught any more about electrical related healing. Now, what does that mean? I don't know. I don't know what that means. But it's this extremely early example of the research itself points in one direction and forces completely outside of the medical benefits of it exerted their financial power to say, don't go that direction. It's an old story.
It's a new story. It's a pervasive story, I should say. You're right. It's an old story, but a pervasive story. And I mean, Tufts School of Nutrition is the primary example right now, because they came out with this food compass that's supposed to, green, yellow, red, about good foods, moderate foods, and bad foods. And then you look at the financial conflicts of interest for the people who created it. And wouldn't you know that the companies they're getting money from, those cereals and packaged products happen to be in the green. Is that a coincidence? Maybe it's just a coincidence. Maybe.
Yeah, I was born at night, but I wasn't born last night.
Yeah, exactly. And we see the same thing in the U.S. Dietary Guidelines. Of course, Nina Teicholz has extensively worked to show the financial influences from the food industry on the dietary guidelines.
Yeah, it's sickening. I don't know how that's allowed. I mean, Nina is such a great investigative journalist and has done so much. I mean, if she wasn't around, how would we know that 95% of the people on the Dietary Guidelines Committee have conflicts of interest, and some of them have 20 plus, and I forget the statistics, but she unearthed all this, and it's mind-boggling. And it's like, okay, are they making recommendations based on health? Or are they making recommendations based on where the money's coming from? And I mean, at first I thought it was skeptical and overly, conspiracy theorist to think it was all about the money, but boy, am I starting to change my tune on that. It's starting to become sickening how much conflicts of interest there are. Yeah.
Well, we're coming up on the top of the hour, and I know you've got a hard stop. I want to make sure that we don't leave any stones unturned that you would like to have turned over. Any closing thoughts or closing words for us?
Wow, I think we've covered a lot of good stuff. I mean, we didn't dive too deep into LDL, which is definitely a hot topic and an evolving topic, thanks to Dave Feldman and Matt Budoff and colleagues in the studies they're doing, which I think is going to be really interesting. Dave presented at Low Carb Denver the preliminary findings, so nothing published yet, but what he's found. So hopefully that'll be published soon. I just want people to keep an eye on what's happening there. And this concept of we can ignore LDL, it doesn't matter, or LDL is the most important thing and we have to focus on it. as is usually the case, it's somewhere in the middle. And LDL is an observed risk factor. But again, it goes down to in what population, in what lifestyle, what else is going on with the person, and how high is the elevation, right? It's a more nuanced discussion. And I think it needs to be factored in with metabolic health, with the person's overall health, with the person's overall lifestyle, and then not just a knee-jerk reaction, but also not a complete ignore it means nothing either. So I think we need to be much more nuanced about that discussion as well. But but again, it takes longer to say that, and it's much easier to whip out your prescription pad and write out a prescription to lower LDL. So that's the frustrating part.
Yeah, we're going to have to certainly have you back, because I think some people will be frustrated that we finally had a cardiologist on with me and we barely even mentioned cholesterol. And honestly, I think that's probably appropriate at this point that we barely mention it. But, because I think it's way over focused. But I'm excited that we got to talk about the other stuff, because I think, honestly, I find that a lot more interesting at this point as well.
Yeah, me too.
Great. Well, let everyone know where they can find you. Of course, we mentioned Metabolic Minds, but where else should people connect with you? And
so
all the great work you're doing.
Well, thank you. I appreciate that. Most of the content I'm putting out now is at the Metabolic Mind YouTube page, and on Twitter at metabolic_mind. And of course, metabolicmind.org. And then I do still see patients in a consultative role for cardiology, preventive cardiology, and that's lowcarbcardiologist.com. So any of those places are the places to find me.
I got to write a couple of those down because they weren't in my email, and I want to make sure they show up in the show notes. Well, Dr. Scher, I have really gotten a kick out of this particular conversation. And I know that clinicians will appreciate it as well. So us normal folks and the educated folks, I think both are going to take something away from this today. Phil, any last words?
I think we covered it pretty well. Like I said, really excited that we finally got to have this conversation. Looking forward to future conversations and to more great work from Bret. So wrap us up, Jack.
Good stuff.
Thank
All right.
you. I appreciate the discussion and the questions. Thank you very much.
So that's metabolicmind.org. Dr. Bret Scher. For Dr. Philip Ovadia, I'm Jack Heel. This has been the Stay Off My Operating Table podcast. We'll talk to y'all next time. America is fat and sick and tired. 88% of Americans are metabolically unhealthy and at risk of a sudden heart attack. Are you one of them? Go to ifixhearts.co and take Dr. Ovadia's metabolic health quiz. Learn specific steps you can take to reclaim your health, reduce your risk of heart attack, and stay off Dr. Ovadia's operating table.